Coming up this week on the forum, I'm speaking with Heather Buesseler of the American Refugee Committee. That's this week on the St. Paul Forum. Welcome to the St. Paul Forum. I'm Catherine Reid, and joining me today is Heather Buesseler of the American Refugee Committee. Welcome, Heather.
Thanks, it's nice to be here.
We're really glad you could join us. Tell us a little bit about what is the American Refugee Committee.
The American Refugee Committee is an international humanitarian organization. We are based right here in Minneapolis, Minnesota, and we provide humanitarian relief and services to communities in some of the poorest and most difficult countries and contexts throughout the world, often emergencies, conflict, post-conflict zones.
It is such a brave kind of work to be doing. It's really inspiring. How is it that you came to do this work?
I actually came to this work through my undergraduate studies. I studied abroad in Africa as an undergraduate at Macalester College here in St. Paul. And I was immediately drawn to the work, and it led me to a career in public health.
Tell us a little bit, just briefly, what is public health? I think it's such an interesting field, but I've been trying to explain it to my daughter, and
yes.
I would love to hear your view of it.
Of course. So many people are familiar with clinical care, and that's providing individual patient care. And public health is coming from sort of the opposite direction, looking at the overall population health, designing programs, behavior change campaigns. You're probably familiar with anti-smoking campaigns that has had really great effects in turning that around. And that's the kind of work that I engage in on a global level, designing programs to affect large swaths of the population and improve overall health for everyone.
So when we think about public health and the kinds of immediate critical issues that you're working on, what kinds of things are you looking at when you're looking in these really critical countries where there are these big conflicts?
We look at issues like health system strengthening, for example. How can we help the existing infrastructure function better? What assistance can we provide to governments and the already existing services to improve the care that they can provide for the population?
Let me stop you, because when I say infrastructure, the first thing that might come to my mind is a road or a bridge. But what do you mean by infrastructure?
We are talking about healthcare facilities, making sure that the water runs, that the electricity is on. We're talking about staff, ensuring that there are enough clinicians, midwives, doctors, nurses to staff those facilities. We're talking about drugs, ensuring that there is adequate supply, that there aren't stockouts, and how we can help the whole pharmaceutical supply chain function better. Things along those lines.
Yeah, that's really concrete. And it's so, I mean, when you say midwives and medicines and water, I mean, you're really talking about some of the most basic things And so does the American Refugee Committee work on the infrastructure piece, or is it more advising?
We do both. At the same time, we are filling gaps like ensuring that staff are there and the water is running. We're also advising host country governments on building their capacity to be able to take on these functions themselves. The goal is always to work ourselves out of a job. We want to be able to put things in place and leave behind a system that hopefully functions better than when we first entered the country.
And so we have so many different populations in this state that we've attracted such a complex array of populations. It sounds like you've been focusing on Africa, the continent of Africa, but specifically which countries are you looking at?
So ARC works in a dozen countries around the world, and many of them are in Africa. They also include a few countries in Asia, Pakistan, Thailand, Myanmar, as well as the Middle East, Syria, and Jordan. In Africa, we also work in Sudan, Darfur region, South Sudan, Uganda, Rwanda, Democratic Republic of Congo, as well as Somalia.
Wow. And specifically, we wanted to talk a little bit about the response you've created for Liberia and the Ebola situation. Can you kind of just give us help us understand what's happening. It's been in the news.
Yes.
There's a lot to try to understand.
Yes. American Refugee Committee is returning to Liberia. It's I hesitate to say our newest country program. We've actually have over a decade experience working in the country. But when the Ebola outbreak happened, there was a call to action by the President of the United States. At the same time, the Liberian American community here in the Twin Cities came to the American Refugee Committee and said that they have been organizing themselves. The Minnesota African Ebola Task Force had developed, and they said that they want to respond. But they wanted to have an organization and a more organized response to help them in a more systematic way, to have a greater impact instead of just going over and see where they could be needed. So with those two calls to action, we started planning with the community to be able to respond to this pandemic that's happening. Currently, there's over 18,000 cases of Ebola in the affected region of Liberia, Sierra Leone, and Guinea, and over 6,000 deaths so far.
So there's so much in what you just shared. I kind of want to unpack a little bit of that. One of the things I'm excited about, as you describe it, is that this sounds like it was a community response. There's a population here. Do you know the number of people from Liberia living in Minnesota?
Exact numbers are difficult to pinpoint for
That's
any refugee community here.
Right.
But we do have the largest community
It's
in
a
the United
concentration,
States.
yeah. I mean, we have several like that. I mean, you mentioned several of the countries you mentioned.
It's true.
I mean, we have the Myanmar population here. My daughter went to high school with a girl whose family has come here, and so we've had a real personal look at that. But I mean, I'm just always struggling. Yeah, the Somali population, we're very high there if we're not number one. So in the case of the Liberian community, again, do you any rough numbers on how many are here or how many you heard from saying what kind of organizational capacity do they have as a community?
There's various community organizations in the Liberian community and the broader West African community as well. There aren't any that had the sort of international capacity that we have and access to some of the United States government donors and United Nations donors that American Refugee has. And so they were really looking to us to provide that institutional home to be able to organize their response.
And obviously, I mean, one of their objectives would be to help contain the virus and contain the outbreak. I know that there has been some success in some countries where they've used some very systematic processes that have controlled it and really tamped it down. And I'm not sure now which country that is. Do you know?
Liberia, actually.
It is
the
Liberia.
Country that we are responding
has been the most successful.
It has. We have been very fortunate, and it actually happened while I was there in September and October. We started to see the numbers come down, and it was really this, it wasn't any one thing in particular, but everything started to happen at once. We had the Ebola treatment units that were going up all over the country to provide the isolation and care necessary to treat patients. The contact tracing started to become more systematic. The community outreach and education pieces started to become prevalent throughout the country. And now the country is even moving more towards responding to hot zones as they pop up. We are seeing declines in cases overall, but there are flare-ups that are happening throughout the country, and the government has shifted their strategy to be able to respond to those, as well as being able to provide care in the fixed facilities. And fortunately, this has all come together to start to bring down the numbers of cases.
It seems to me that there's just been a deep concerted effort to educate people. Fear is such a pandemic of its own, and it does seem as though that's been a really important aspect in this crisis. Is to help people to provide the education to understand what makes it contagious, how to handle it. What wisdom do you have to offer so that just the average person listening to the stories about Ebola, what is it that's useful to know and understand?
It is useful to know that Ebola can only be transmitted when a person has active symptoms. So the fever, the nausea, the vomiting, they are not contagious before that happens. So the average person walking around, even if they've been to Liberia, Sierra Leone, if they come back, it's not like polio, for example, where you can be actively contagious and you're not feeling any symptoms. So that's the number one thing that I think is important for people to understand. In Liberia, there's also a big education campaign just to raise awareness among community members that the virus is real. You see posters and signs all over town with that very simple message: Ebola is real. There was a lot of resistance in the beginning to accept that this was an actual disease, that it was affecting the country and this larger region as a whole. And the campaigns have been very successful in educating the community, and now it's moving beyond that and trying to give messages of hope to people that if you get to a treatment unit early, you have a greater chance of surviving the disease. So we're seeing the messaging.
Really important.
It is, and we're seeing the messaging shift along with the epidemiology as it's been shifting in country.
And there seems to be a lot there that I'm fascinated by the idea that it just wasn't perceived as real. And can you think of other diseases that's been true of? Is it?
I think if we look at the early days of the HIV epidemic, there was a lot of resistance in Africa that the disease was real, about how it was transmitted, a lot of perceived, I guess people were wary about the international interest in responding and how they were doing that. And so I think a lot of vestiges of that we may have seen as well in this epidemic as it came up.
And so, you know, there's so many things going through my mind because I've been listening to a lot of radio programming describing putting on the suits, the number of times you have to change it, how careful you have to be in that. You have, is your work involved in training and assisting people specifically with the illness and that level of care? Is that part of what you're doing?
Yes. So the American Refugee Committee is responding by setting up, managing, and providing clinical care in an Ebola treatment unit. We will be managing one of 15 in Liberia. So there's one in every county, at least one in every county, and more where there's greater need. So we will be managing one in a place called Fishtown. It is on the southeastern part of the country, near the Côte d'Ivoire border. And what is so critical about this location is the fact that it's near the border. And we need to be very concerted in our efforts to ensure that it is contained within the borders of Liberia and that it doesn't spread further within the region. We've seen cases pop up in Mali, in Nigeria, in Senegal. Luckily, they were contained very quickly, but we want to ensure as an organization that it doesn't jump the border. And the best chance of success that we have is to be able to provide the isolation and clinical care to patients in an Ebola treatment unit.
That's probably one of the scariest things too, is that isolation piece of it, I would guess. Maybe that's not the first thing that, as you said, you're trying to just get people to recognize it's real, to understand what the symptoms might be, and then how to treat people. There's a sadness I feel around the whole isolation of a child perhaps losing their parents, and then that child is shunned.
Right.
I mean, I've heard those sorts of stories. I mean, and this idea of not jumping a border, I can't picture that right now. What does that border look like? In other words, we've just crossed the border between St. Paul and Minneapolis, and it's an invisible border as far as we're concerned. So what does it look like there?
It's very much the same, except it's not in
a
jungle.
It's not a big. It's a jungle, so it's even.
Yeah. So it's even more difficult to envision. I mean, at least Minneapolis, St. Paul, you have the river to guide you.
Roughly.
But you have that imaginary dividing line, and it's much more fluid along this border.
So what are the specific strategies then for that? How does that?
Well, as I mentioned, we have the Ebola treatment unit that we're setting up in this border county. And there's other organizations that are participating in the response that are doing community education and outreach, both on the Liberia side as well as on the Côte d'Ivoire side, actually, to start to prepare those communities as well to know what to look for. Contact tracing is a very important part of ensuring that the disease...
Let's hold that thought because I want to ask you a little bit more about
Sure.
that. If you're just joining us, I'm speaking with Heather Buesseler of the American Refugee Committee about their response to the Ebola outbreak in Liberia. What does that mean, contact tracing?
Sure. So for each person that contracts the disease, we want to find out what contacts that person had with family members, friends, other people they may have interacted with in the community. As I mentioned, you're only contagious if you are symptomatic, and you actually have to come in contact with the bodily fluids of that person. But there's a lot of interactions where that might happen. Liberia is a hot place. You can be sweaty, and you might be in a taxi crammed full of people. You hug your family members, you kiss your kids, you might share utensils, or maybe the plate, you finish the rest of your mother's dinner, and the fluid that you may have transmitted in those interactions is what transmits the virus. So contact tracing is the process of identifying all the people that this person may have come in contact with during the 21-day incubation period of the disease. And then those people get on a roster, and they are monitored for 21 days to see if they develop symptoms. And it's by this active contact tracing that we really get to the bottom of this, and we get to our collective goal of 0 new infections.
That sounds very, very daunting.
It is a very complex process, but with the number of actors that we have on the ground currently, the ARC is not taking on all of this work. We interact with the county health departments, with other international non-governmental organizations, with the Liberian government, and collectively we're able to implement all these different pieces, and it's shown to be effective so far.
That's great.
That being said, just because cases are declining, it's not over yet.
Yeah, it's still really important. Talk a little bit about that complexity and the danger, that's real. What is the word that's coming to me is commitment. Where does this commitment come from by all of these organizations, and can you describe that?
I think for all of us, it's a moral obligation. There is a very real crisis affecting other human beings. It doesn't matter that they're not here in this country. There are so many people that are falling ill, so many people that are unfortunately dying. It's the same if an earthquake happens, if a war breaks out somewhere. I mean, this is the level of disaster that we're dealing with. Yes, it's a health issue, it's a pandemic, but it is a humanitarian emergency, and I think we have an obligation as other human beings to respond, to help fellow humans.
And is the expertise that you have to offer, can you describe what's distinctive about it for this, what you bring to the table?
American Refugee Committee has a history of responding to emergencies. Prior to this, we were responding to the typhoon, the super typhoon in the Philippines earlier this year. We've responded to earthquakes in Haiti, in Pakistan. We assist in conflict and post-conflict settings, internally displaced people. We provide care and services to people in refugee camps when they actually have to leave their countries. So we're particularly well-placed and well-versed in the strategies to deal with these kinds of complex emergencies and humanitarian situations.
And what's your relationship to places like Paul Farmer's organization or Doctors Without Borders? We hear a lot from Doctors Without Borders. We probably hear spokespeople from the American Refugee Committee as well, but I tend to hear those. What's the relationship, and what makes you each distinctive, or are you similar kinds of organizations?
So they are other international non-governmental organizations like ours that are also participating in the response. In fact, Paul Farmer's group, Partners in Health, is implementing Ebola treatment units in neighboring counties as American Refugee Committee. So
you'd be collaborators, essentially.
Exactly.
You've staked out each of your territories, and you're concentrating on a specific territory.
It's a county-by-county approach,
Nice.
and we are collaborating, for example, with Partners in Health to ensure to maximize efficiencies when it comes to supply chain, to identify suppliers of personal protective equipment. Médecins Sans Frontières, or Doctors Without Borders, were one of the only organizations that had any experience responding to and treating Ebola in the past, much smaller situations.
They were, or you were? I missed what you just said.
They were.
They were, okay.
So they have been really at the forefront of providing the clinical guidance, sharing what they had already developed in terms of how to treat this, and then working with the international community to scale those treatment methodologies up to the level that's necessary to respond.
Nice. So that makes a lot of sense, and I'm thinking of a parallel that, you know, we are a center for so many nonprofits in the Twin Cities, and people have to figure out what's the best place to support, you know, to put my dollars or make my investment or talk about with other people, raise awareness of it. And so I'm just always curious, how do we make those choices?
Right.
And it sounds like there is a really collaborative relationship, but we have some really strong expertise here that we're bringing to the table. What about your specific experience there? Tell us a little bit about, you're just back relatively recently, and what was that like?
It was an invaluable experience. It was a humbling experience to be a part of this response. I was there essentially doing all of the legwork to establish this Ebola treatment unit that the American Refugee Committee will be running. So we were signing agreements with the Liberian government that we would be doing this. We were working with the U.S. government, our donor, to identify where in the country we would be best placed to set up this Ebola treatment unit. Working with other organizations like Partners in Health to operationalize some of the logistics around this, learning about some of the social mobilization and behavior change activities, working with the county health team to find out more about the functioning of the essential health services, which have largely, it's gone very downhill because all the attention has been focused on containing Ebola. So really looking at all of these pieces and putting together a response. And I guess what was really amazing to me was this collaborative feeling that we've been talking about among all of the people involved in the response, all of the organizations. Sometimes in the work of NGOs and the international development world, it can be a bit competitive. And what was really encouraging to me is to see the way in which everyone was on board. We were willing to adapt our strategies to work with the government, working with the various United Nations partners to create the best response possible. We're all working towards 0 new infections.
So having that larger vision, is that part of what's pulling it together, do you think, that reducing that competitiveness? It sounds like that's been a really big idea.
Yes.
And I mean, it's very inspiring. My mother had polio when she was carrying me, and you mentioned polio. It's almost eradicated, you know, but at the time that I was growing up, it was a very scary thing, not unlike what we're talking about. But through interventions and through great science and through generosity, actually, in the form of, you know, Jonas Salk didn't take money for that. He said, no, we have to make this available to the world. And it sounds like that bigger vision is an important driver. What is your wish for people here in Minnesota to understand about both our Liberian community here and about what you're doing?
What I want them to understand is, I think one of the unique things that the American Refugee Committee brings to the table and to this response is this community engagement piece. I think we're one of the few organizations out there that is really responding to a voiced call and need from their own backyard, from the Liberian expatriate community that is here. And I think together that collaborative relationship really makes our response so much stronger and relevant when it comes to making community connections. Our medical director, actually, for the Ebola treatment unit, her family actually is originally from Fishtown and the county where we're interacting.
So it's very personal.
Very personal for a lot of the people that are involved in the response.
And it sounds like because of that on the ground and community response, that it is more authentic to what's going to work in that community. Is
Definitely.
that been your experience?
It has been. I mean, the mayor of Fishtown, for example, practically jumped up and hugged the doctor that is the medical director when she found out that, you know, her parents, her ancestors are from that area. She was so pleased to see her coming back and giving back to her community.
I would think it would really increase trust.
Definitely.
From both sides.
Absolutely.
Yeah. It sounds really great. So you've been talking about when you were in Liberia itself. What did you observe there in the community that was going well?
So it was so encouraging, despite some of the hesitancy perhaps to accept the existence of this disease. I think there is some internal acceptance. Everywhere you went, and especially in Fishtown, in this very remote area of the country, you see the chlorinated water stations outside of every single little shop. You go into any grocery store, any small restaurant, and you are forced to wash your hands in the chlorine water. Even in front of every person's house, you see this. People are very actively trying to avoid contact with people. They've stopped shaking hands. And some of this goes very counter to a lot of the accepted cultural norms, but people have recognized that this is what it's going to take in order to bring this under control.
Yeah, that makes so much sense, but I'm sure it's really challenging too.
Definitely.
But you see really visible signs, it sounds like, of these systems that you're talking about. It's a form of a system, it's infrastructure, if you will.
Yes, yes.
And
The behavior change, messaging has really taken hold and become institutionalized.
Great. So there are some needs. Are there opportunities for people to volunteer? Are there opportunities for people to contribute to what you're doing?
Absolutely. If you want to learn more, if you want to contribute, you can go to American Refugee Committee's website, which is www.arcrelief.org.
Okay. And I assume that there aren't volunteer opportunities to actually go into Liberia because of the level of training and expertise. Is that a correct assumption?
You can look on our website there are employment opportunities for the response itself. It does require a high level of training.
High level of training, yeah.
But for those that may have the inclination or the experience, I welcome them to also look for those opportunities on our website.
I assume it's very rewarding work.
It very much is.
Yeah, it looks like it has been for you. And do you have a horizon on how soon you think this zero, how far out is it, do you think?
I hesitate to state a date. I know that everyone is putting every effort forward to get to that zero mark as quickly as possible. We will be running our Ebola treatment unit at least through May. If the needs dictate, we will stay there until we do reach that zero baseline.
Fabulous. Well, thank you so much for what you're doing. It's very inspiring and great to hear about it in our own hometown.
Thank you.
So thanks for joining us. That's all we have time for. Come join us again next week on the St. Paul Forum.